This case was recently shared on Twitter of male 60 years old presented with a cough for 1 month duration. And when he suffered from shortness of breathing, he was admitted by ER after doing X-ray. This is the X-ray showing widespread of nodular opacities in chest X-ray and underwent high resolution CT, showing the multiple nodules of countless nodules. We have left lower lobar pneumonia-like appearance or consolidation with air bronchogram and left pleural effusion. So we have here what you think either there is infection or a neoplasm because of this left lower lobar pneumonia-like appearance. Placing the nodules in the correct distribution will solve the issue. The random distribution is shown well here. We have nodules along the major fissures and along the pleural surface, which exclude centrilobular distribution, which will exclude as well the endobronchial spread of infection. So we have two options now. Is this distribution is perilymphatic or random distribution? The distribution here is not in respect with the interstitium along the bronchovascular bundle and interlobular septa. So we can exclude even sarcoidosis. If someone think of sarcoidosis, this should be excluded. So we have randomly distributed nodules. We have here two choices. Is it miliary infection due to hematogenous spread or metastasis hematogenous spread? The miliary infection due to TB or fungal infection, the miliary pattern is pinpointed nodules, much more smaller in size. They are very tiny nodules and more in number. Here we have great number of nodules, but in miliary infection, they are tiny and much more in number compared to these nodules, which are large and variable in size. This is in favor of metastasis over infection. This will solve the problem of finding a pneumonia here and will exclude our thoughts about infection. And we are having here a case of mucinous invasive adenocarcinoma that can present with pneumonia-like appearance. And here, the placing of the nodules in the correct distribution solves the issue. And it plays the same role of lymphangitis carcinomatosis. Orientation of the reticulation of smooth interlobular septa also can solve a problem of finding such pneumonia-like appearance, and this will deny the infection and will be in favor of a neoplasm. I'll show you also the coronal scan showing the random distribution along the fissures and the pleural surface without respect to the bronchovascular bundle and interlobular septa location. Here also, we have the sagittal scan showing the major fissure nicely and the minor fissure with resting nodules. Here you can also appreciate presence of cavitation or air bronchogram within the nodules. This is not against the metastasis. I will proceed about talking about the cavitation and air bronchogram after this scan. I want to also mention an important point regarding mucinous invasive adenocarcinoma. MIA has tendency to be aggressive from its name, mucinous invasive, aggressive in parenchymal changes, but not as the same in regarding the nodal involvement. Here you can have insignificant or not bulky lymph nodes involved by the tumor, same as the other types of lung tumors like small cell lung cancer or squamous cell or large cell carcinoma. They have tendency to involve the mediastinal lymph nodes by bulky involvement of the nodal affection, but here it's not as large nodules, and we are hardly appreciate here. It's hard to assess the nodal involvement in case of non-contrast study, but we don't have bulky that it's eye-catching for us. Now I will proceed the point talking about the multiple lung cavities. Metastasis is among the differential diagnoses of cavitary lung disease, and also it's one of the differential diagnoses, adenocarcinoma, metastatic adenocarcinoma, if presence of air bronchogram within the nodules. And these two topics, cavitary lung disease and air bronchogram, can be uploaded in near future in specific lectures. And thanks for your attention.